So today we're going to be going through different tricuspid valve interventions and really like sitting in the lab the last month, seeing some of these devices because they look a lot more foreign than what we're used to seeing. Really kind of inspired doing this lecture series today. So I continue to not have any conflicts of interest to disclose, but I do put the disclaimer that much of what I will be presenting will be information provided either by the device companies or from trials funded by the device companies, because these are investigational devices for the most part. So the overview today is really to look at a potpourri of intracardiac devices in the tricuspid position. We're going to talk about some procedural aspects of how these devices are deployed and implanted, and then we're going to look at important factors in follow-up of these patients. And this is a selection of some of the different devices we're going to look at. If you look at the bottom right corner, these look quite foreign. They look like large stents, and so these are some of the heterotopic valves, which are quite unique and type of valve we didn't talk about last week with the valves in the mitral position. So the objectives are to review unique cases from St. Michael's Hospital Echo Lab and Structural Program, to describe the rationale for why you might choose some of these devices in the management of tricuspid valve disease, and then to appreciate pearls and tips in image acquisition and interpretation for structural heart cases. So some of the devices are approved for commercial use, and that's really just the TriClip is what we'll be talking about today from that end. And the vast majority of devices we're going to talk about today are still investigational. Principles regarding how we assess these valves will be described, and it'll be interesting to see what kind of wins out in the future with these devices in terms of what will become eventually commercial and more widely used. And so you may see some of these devices in your lab in the near future, and then certainly in the far future. I expect some of these will win out. So the first device we'll talk about today is the TriClip. And much of the principles regarding edge-to-edge repair for the tricuspid valve for the mitral valve, what we talked about last week, hold true for the tricuspid valve. The idea is if you have a leaky valve, you have leaflets that don't coact properly, there leads to regurgitation. By putting a clip on the valve leaflets, you can help bring the leaflets together. It creates a tissue bridge and helps reduce regurgitation. So a lot of what we talked about in the previous lecture. Now, the TriClip has multiple different sizes. There's this NT or NTW. The W means the clip is wider, and so that can be helpful for grasping specific types of leaflets. And then you'll see the XT and XTW. So you may see these in the procedural reports. It's helpful to include as part of the echo report. And so the XTW is a larger clip. The X refers to kind of it being larger. So tricuspid edge-to-edge repair we know that it's safe and it's effective for reducing tricuspid regurgitation for suitable patients. And really, these are patients that don't have a very wide coaptation gap. You're able to grasp the tricuspid valve leaflet tissue to help reduce the degree of regurgitation. And in terms of implanting this, there's a variety of configurations of the tricuspid valve. We're starting to understand more and more that there can be different segments to each of the three leaflets, and so it can almost look like there's 4 or 5 leaflets sometimes. And so these are considerations that are taken into account when implanting the TriClip. So the TriClip was studied in the TriLuminate trial. This was published in the New England Journal of Medicine 2023, and this was a randomized controlled trial of patients who received TriClip plus medical therapy versus medical therapy alone. And this was a positive trial in that the composite of the primary outcome was reduced, but it was mainly driven by improvement in patients' symptoms. There wasn't actually differences in terms of heart failure hospitalizations or mortality in the short, in the time period in which they monitored the patients. And so it led to some criticism. Did the patients who got TriClip feel better because they knew they had a procedure performed, right? Was there a placebo effect here? And this figure from the trial, I think, shows that if you reduce the degree of tricuspid regurgitation, patients do feel better. So just focusing on box A over here, this is the increase in the PCQ score. So a higher score, an increase in score, means patients felt better more. And so in patients who had moderate or less tricuspid regurgitation, there was, the scores tended to be higher compared to those who were left with severe, massive, or torrential tricuspid regurgitation. And then looking at box B over here, see that the number of grades in which tricuspid regurgitation was reduced. So for example, if you had a 2 or more grade reduction in tricuspid regurgitation, as shown in this box over here. So if you went, for example, from severe to mild, patients tended to feel better. So there was almost this dose-dependent effect that the more you reduce their tricuspid regurgitation, the better the patients seem to feel. And so that's hard to explain to a placebo effect alone. It seems like there's a dose-dependent response with the degree of tricuspid valve regurgitation. So using this therapy can help patients feel better with respect to reducing tricuspid regurgitation. So this is an example of a patient pre and post TriClip. On the left-hand side, you see an RV inflow view, and there's a wide, large jet of severe tricuspid regurgitation. And then on the right-hand side, you see a sweep through the RV inflow view for the same patient. You can appreciate that there's a TriClip attached to the patient's tricuspid valve leaflets, and the degree of tricuspid regurgitation has been reduced significantly, now probably mild overall. And this is a different patient, and this is a view of the tricuspid valve in the short axis. And I show this view because it's kind of a nice one to see. You can actually see this patient had 3 TriClips attached, and so it's demonstrated very, very nicely here. Now grading tricuspid regurgitation in this view can be challenging, so multiple views are obtained, and overall it's felt we had moderate residual tricuspid regurgitation, reduced from severe or more. And this is a different patient who also had 3 TriClips attached, so three clips on there, but they continued to have severe residual tricuspid regurgitation. And it led to the question, what can be done if more clips can't be placed? If you don't have enough tissue to grasp, or it's just not feasible to place more clips, what can be considered? Well, the team at St. Mike's is quite creative, and so an idea was brought up to use this occluder device. So the Gore occluder device is a device that's used to plug things, basically plug VSDs or plug paravalvular regurgitation from mechanical valves, for example. And so it's a plug type device. So the idea is, can a plug be placed in between tricuspid clips to help plug regurgitation? And so this is an example of the TE pre-procedure. And you can appreciate 3 clips on the tricuspid valve there, and there's a severe degree of residual tricuspid regurgitation. So these are some of the procedural images. This is the same view on the left-hand side, showing a wire being placed in between the clips where they want to place the plug. And then on the right-hand side, you see fluoroscopy. And you actually see there are 5 clips on your screen, so the patient actually has 2 clips in the mitral position as well, which we don't see on the echo because we're focused on tricuspid here. But so there's now a wire with fluoroscopic and echo guidance being placed in between the clips where they want to deploy the plug. And then this is on the left-hand side is the plug being opened up and deployed where they want it to be. And then on the right-hand side, the plug has now been deployed. And so this is a pre and post, showing the images pre, which we saw before on the left-hand side, showing the severe degree of tricuspid regurgitation. And then on the right-hand side, you can see there's this bulky kind of metal material within around the clips, and so that's the plug with the fabric mesh to help plug things up. And you can see the degree of tricuspid regurgitation has been reduced significantly. And so this is transthoracic echocardiogram pre and post procedure. In the short axis view of the tricuspid valve. And again, pre, you see this large jet, wide jet of tricuspid regurgitation. And post, you see there's probably mild to moderate overall residual. Now because of this plug and multiple clips, there's often multiple different jets. And so the sonographer, fans through and sweeps through to try to identify this, and that's quite helpful. And overall, it's felt to be kind of mild to moderate residual. So overall, good effect here.
Right. The occluder device was placed between 2 clips that were attached to the same leaflets.
I think they were attached to the same the same 2 leaflets, the commissures. Yeah.
Yeah, like ES or
exactly.
Kind of makes sense how it would be. So that they're aiming at looking at plugging the regurgitation. That's obviously between the 2 clips within the same 2 leaflets.
Exactly.
More challenging to do with clips is different.
I imagine so. Yeah, exactly. So you may ask the question, well, we've put a plug in here. What does that do in terms of the gradients through the valve? And so this is showing the CW Doppler through the tricuspid valve. And the mean gradient pre-occluder device was 6 millimeters mercury, and post was 5. So there wasn't any significant increase by plugging this up. So overall, this is an excellent result. And I think it shows that, a creative strategy to help manage patients when more clips can't be placed. So the next part we'll talk about is transcatheter tricuspid valve replacement, or TTVR. And so much of the principles of TTVR are similar to TMVR, which we talked about last week. And so this is, to be used for patients where clip is not feasible. So for example, they have very large coaptation gaps that, you simply can't close it up by grasping two leaflets. Or if the leaflets not have insufficient qualities, it's too thin to actually grasp, or if there are excessive cords, that can also make placement of a clip very challenging. The other consideration for TTVR is when you want to abolish tricuspid regurgitation. So you want to go from severe to trace. So often with a TriClip, you're left with kind of mild residual or moderate residual, which is nice. It's a gentle intervention that reduces the degree of tricuspid regurgitation. Doesn't necessarily eliminate it, but it reduces it, and that helps patients feel better. But can we obtain better outcomes perhaps by going from severe to trace, for example? And that's being investigated in clinical trials right now. The valves we'll talk about are the Evoke, the Cardiovalve, and the LuX valve, all which have been used here at St. Mike's. So this is an example of a patient who is pre-TTVR, and you can appreciate, looking on the left-hand side, the patient has a very large right atrium. The volume index is 254 ml per meter squared, and the total volume was over 400. So it's a very large right atrium. The right ventricle was also severely dilated. The basal dimension was 56 millimeters. And you can appreciate that there's a coaptation gap between the tricuspid valve leaflets, and this was measured to be this is a 2D gap of 12 millimeters. So this is a patient that wouldn't be a good candidate for a TriClip. All the chambers are very dilated. There's a large coaptation gap, which makes the procedure technically extremely challenging. So this could be a good patient for a TTVR. So this is the Evoke valve. It's a valve that's been used commonly here at St. Michael's Hospital. There's 3 sizes that are shown here on the screen: the 44 millimeter, the 48, and the 52 millimeter. There's a 56 millimeter valve that's also in development. So they're getting kind of bigger and bigger to address patients who have larger and larger annuluses. This is an example of the delivery system down here. So it's a transfemoral venous delivery system, and it's implanted through a 28 French, so a large sheath. It makes sense to implant these large valves. You need to be implanted through a large sheath. And these are some of the characteristics of the valve, which we'll talk about. So it has these 9 anchors around it. And the idea is these anchors, when they're deployed, help to grasp the native tricuspid valve leaflets, the cords, the valve annulus, and then that'll be wedged between the actual body of the valve here when that's expanded. There's a skirt that's shown here, and so this skirt will help to hopefully prevent paravalvular leak and regurgitation. And then there's a Nitinol frame that's on a self-expanding design that will help to conform to the configuration of the patient's tricuspid valve annulus. And then there's, internal, the valve itself is bovine pericardial tissue, the same that's used for the SAPIEN valves. So this is a video demonstrating, how the Evoke is deployed. It's a transfemoral venous system. So the system is, goes up to the IVC, goes into the right atrium, and then goes through the tricuspid valve. There are various controls that help the operators line the device up in the appropriate position. And the next step is that the anchors are deployed. So the anchors are first released, they fold back, and they try to grasp the native tricuspid valve leaflets, try to grasp some of the cords, and that will be useful in helping to anchor. Then the body of the valve is deployed, and so that's the skirt there. And so the skirt will sit on the atrial side and help to prevent paravalvular regurgitation. And then the valve expands, and the self-expanding design helps to conform it to the native tricuspid valve annulus design. And then the anchors are wedged between the cords and the native tricuspid valve leaflets and the skirt and the body of the valve, So that is what helps actually anchor it in place when they're happy the valve's deployed. And so this is a view of the valve, just looking at it from the side of the right ventricle. You can appreciate how these hooks and anchors grab onto some of the cords and then hook up to grab onto the body of the device and help to anchor it in place. Really clever design. These are some procedural images just showing the TE and how it's performed. So looking just at the red box here is probably the most easiest to understand. You have the RA here where my cursor is, RV, tricuspid valve, and then the deployment system going through the tricuspid valve annulus and in between the leaflets. And so this is lined up. This is like the first step where the delivery system is going through the valve. So this is what they see in the procedure. And then the hooks are starting to be deployed, so you can appreciate how from the 3D view and looking here, you have the hooks and anchors start to be deployed, and they take this shape, and then they're trying to grasp these cords and the native tricuspid valve leaflets. This is fluoroscopy, and you get motion sickness. Maybe just turn away for a second here because it's going to turn. But I thought this was a really cool loop because it shows how the anchors are being opened up, and the operators with TE and fluoroscopy are lining this valve up in the position that they like. And then at this point, now the skirt and the body of the valve is being deployed. You can appreciate how on the fluoroscopy on the right-hand side of your screen, just get the cursor moving again, now the hooks are hooking up and grasping on to the cords and leaflets, and the body's being deployed here. And now the valve is deployed in this view. You appreciate on the 3D how there's this kind of round, this is where the internal stent of the valve is, where the bovine leaflets are in the middle here, and then the hooks will grab around that from the ventricular side to help anchor it in place. And this is some nice fluoroscopy. It's a little dark on our screen here, but this is nice fluoroscopy just showing the valve that's expanded, and you can see it looks very stable and anchored in place within the tricuspid valve annulus. One thing you'll notice is that the patient has a pacemaker, so the idea is that this valve is deployed around the pacemaker lead. The pacemaker lead stays in position. They're careful during the procedure to mind the position of the lead. But the leads have been in there for years, and they're very stable. And so the lead itself, where the arrows are, is around where it's sort of in between the native tricuspid valve annulus and then the annulus of the evoke valve. And this is helpful to be mindful of, because if you scan in this area, you can often see paravalvular regurgitation in this area. So this is a helpful area to look for when you are assessing these patients. So the EVOKE was studied in the TriSend trial initially. This was a prospective single-arm multi-center study, and looked at patients with symptomatic tricuspid regurgitation, moderate or more. And it showed, and this was an initial trial showing feasibility and safety. And what they found in the single-arm trial was that patients who received EVOKE at 1 year had 97.6% had mild or less tricuspid regurgitation compared to this distribution here. Most of which had severe or more tricuspid regurgitation. And then the patients seemed to feel better too. 93% were NYHA class 1 or 2 at the 1 year mark, compared to most being class 2 or 3, pre-intervention. So with this, the TriSend 2 trial is ongoing. This is looking at the EVOKE valve with optimal medical therapy versus optimal medical therapy alone for patients with symptomatic severe tricuspid regurgitation. And the outcomes that will be looked at will include the degree of tricuspid regurgitation reduction, mortality, heart failure, NYHA class, and KCCQ scores. So stay tuned. This is something that we'll see in the future to see if this alters our patients' outcomes in a randomized controlled trial fashion. So let's show some pictures pre and post. So on the left-hand side, you see a patient who's had this is a patient who's had TTVR with the EVOKE valve. The pre-pictures are on the on the left-hand side, and you can appreciate this, large and wide jet of severe tricuspid regurgitation. And post-TTVR, the valve looks well seated. We'll go over some of these images in a more zoomed fashion, but there's a trace intravalvular and trace paravalvular regurgitation around that that lead. But the point is that the degree of tricuspid regurgitation has been reduced significantly by this intervention. This is how the valve looks without color. So looking at the RV inflow view on the left side, you can appreciate the cage of the evoked valve, and you can appreciate the bioprosthetic leaflets you can actually see moving in part of the. And then on the right-hand side, this is how the valve looks in the four-chamber view. You appreciate just how bulky these valves are. This is a color compare looking at the RV inflow view, and the sonographer is sweeping through. And you appreciate there was a trace jet of intravalvular regurgitation. And as you start to see the pacemaker lead there was a trace jet of paravalvular regurgitation. We'll just watch that one more time. The intravalvular regurgitation is going to come up shortly, right there. And then sweeping through to the pacemaker lead, which we saw right there, there was a jet of trace paravalvular regurgitation. So overall, a nice result and a good demonstration of how sweep is helpful here. This is again a color compare with sweep that shows a trace jet of intravalvular regurgitation. And then as you get closer to the pacemaker lead, the inferior aspect of the valve, there's trace paravalvular regurgitation. Another thing to comment and be aware of post TTVR, this is a different patient. Is paravalvular regurgitation during systole or diastole? Oh, good question, Josh. Should be during systole.
Yeah, actually, I was going to make that point. The one thing to note is that sometimes, so what Josh was referring to was that actually you can actually see a bit of inflow in diastole through the same area. You see a little bit if you go back to one of the previous ones. There's a bit of red flow around it as well in diastole, and then you see the blue flow in systole. So sometimes actually the red flow in diastole, that inflow, is actually more visible than the regurgitant paravalvular leak. So, but if you do see that inflow around it, then I think it's a good signal that there probably is at least some degree of paravalvular after.
Absolutely, yeah. That's when slowing down and kind of going frame by frame, when having the image live will be helpful. Perfect. Okay, so another thing to comment and be aware of is the right ventricle. So on the left-hand side, you see a patient pre-TTVR, and then on the right-hand side, you see a patient the same patient immediately post-TTVR, and the images aren't lined up exactly the same in terms of the acquisition, but I think we can appreciate that the right ventricular systolic function appears reduced than compared to pre-procedure. And so this is a concept we talked about last week about afterload exponential. And the idea is that when the patient's right ventricle has a mechanism for severe tricuspid regurgitation, the venous pressure is much lower than the pulmonary pressure. And so that severe tricuspid regurgitation offloads the right ventricle. And so when that's abolished, you go from severe to trace, the afterload the right ventricle feels is increased. Now, the forward stroke volume is going to be improved because you don't have this severe degree of regurgitation, but this may lead to transient decrease in the right ventricular systolic function. These patients may be temporarily hypotensive, may require fluids to increase RV preload, may require inotrope suppressors. That's often short-lived, and the RV tends to improve and recover quite quickly. And so this is the same patient. On the left-hand side was the clip immediately post-TTVR, and then on the right-hand side is 1 month post-TTVR. And I think we can appreciate that the right ventricular systolic function looks improved with time. So that's nice to see. It was quantified and it was felt to be kind of low normal compared to moderately reduced immediately post-procedure.
After the assessment of RV systolic function after these very, very bulky TTVRs is very challenging. I don't know what you think.
Yeah, I was talking to Neil about it yesterday because this week we put in a number of LuX valves.
Yeah.
And they're much softer valves, so it sort of feels conceptually that you get a bit more angular movement, so you're less likely to induce this phenomenon. I mean, we don't really know because as Howard said, we're not great at quantifying with our assessment. It's just been clinically, we see less of this sort of acute dysfunction afterwards with the, they get a bit hypotensive, the creatinine goes up, you get the sort of forward flow issues as their RV blows out. You just see less of it. But interestingly, with the LuX valve, we see more of this sort of acute febrile SIRS type response afterwards. So each of the valves seems to have quite a different profile and so on into how people respond.
Yeah.
So I think it's we're learning a lot about what happens when you anchor that annulus and everything else that comes with it.
No, let's say the profile is pretty large, so it just projected to the RV. And for example, TAPSE, I'm not sure if TAPSE means anything.
Right. Yeah, exactly.
I've just looked at the RV free wall predominantly and thought, okay, it looks okay. That's a visual, which is not very quantitative.
No, that's true.
For this patient, the fractional area change was actually calculated and measured for this patient, and the actual were nice echo contrast images.
That might be
here.
Yeah.
Right?
Yeah, sure. Yeah, I think for the TAPSE, it doesn't make a lot of sense when we anchored the annulus to now try and use that as a measure of function.
And your RVS prime is going to be affected by this.
Same
reason, right?
Presumably yes.
Yeah, it'd be interesting to look at with a cohort of our patients here and just kind of see what these parameters are and describe that. I'm not sure if that's actually been described. So another thing to look at with patients, aside from the systolic function of the right ventricle, is the size. And so this is an example of a patient on the left-hand side was immediately post TTVR, and pre-TTVR their right ventricle was very dilated. And post you can appreciate how much smaller that right ventricle is. You can appreciate on the left how it was really the same size or bigger than the left ventricle, but on the right-hand side with that clip, the RV looks fairly normal in size. It looks smaller than the right ventricle, and it's shrunk significantly. And so this sort of makes sense. Is that tricuspid regurgitation is a volume loading lesion. The right ventricle will feel more volume because of the regurgitation back to the right atrium and that cycling of blood. And so over time, we're appreciating that the right ventricle is quite plastic, and we knew this from the surgical world as well. But that the right ventricle can indeed remodel. And this was an interesting case report published in JACA case reports of a 84-year-old woman post-evoke who had her various echo and clinical parameters monitored over time. And what was seen is that at the around the 6-month mark, between baseline and 6 months, there was a significant decrease in the RV diastolic volume and the systolic volume. The systolic function of the right ventricle was preserved, but over time, with that removal of that volume loading lesion, the right ventricle can remodel, and that's something that can be seen in follow-up echo as well. So the next valve we'll talk about is the Cardiovalve. We won't spend a lot of time on this because it's the design and the deployment features are quite similar to the Evoke valve. This is a video from the company that shows how the valve is deployed. There are some changes in terms of steering the valve and deploying it properly. The valve has a similar sort of hook design that tries to grasp the leaflets and the cords. So first tries to grasp that. It then has this frill or a flange or skirt that expands, and then that helps to reduce paravalvular regurgitation, and then the internal stent is released and deployed, and that helps wedge everything together to anchor the cardial valve in place. Similar principles to the Evoke. This is a case series that was published by the group here at St. Mike's that goes over our experience in patients with the cardial valve. So if anyone's interested, they're free to look at it. This is showing some of the outcomes in terms of the reduction in tricuspid regurgitation. So it was effective in doing so, but the article also has some tips regarding anticoagulation and managing these patients post-operatively, as Dr. Connolly was saying, kind of the expected clinical response to patients. This is a helpful case series if anyone's interested. This is an example of a Cardiovalve. This is in the 4-chamber view. You can appreciate the stent and structure of the valve. You can, from time to time, appreciate the bioprosthetic leaflets within the cage of the valve, and then you can appreciate that there's a pacemaker lead that goes around the valve. You can't see it going around the valve in this one view, but you can appreciate that there's a lead that goes in the right ventricle, presumably around the valve. This is where sweep again is helpful. So we're looking at some intravalvular regurgitation there. You can also appreciate paravalvular regurgitation, which was shown nicely with a bit of a zoomed out view and a sweep through the valve. You can appreciate that towards the RV free wall, there's a trace jet of paravalvular regurgitation and then towards the interatrial septum, there's another jet, a tracer mild, paravalvular regurgitation here. And grading these can be a challenge. They look small and thin, so probably tracer mild. And the last CTVR we'll talk about is the LuX valve, and that's shown here. It's a very bulky valve. The valve, has various sizes, but now up to 65 millimeters. So this can be useful for a patient with a very large tricuspid valve annulus. This is a view of the valve from the atrial side, where there's this skirt anchor on the atrial side, and then it has a very interesting design for how it actually anchors into the tricuspid valve annulus. It has these two rabbit ears or bunny ears here that will try to capture the native anterior and posterior tricuspid valve leaflet. So that's one of the ways it anchors. And then it also has this septal anchor here that gets secured to the septum of the right ventricle, and that's another way in how it anchors. So I'll show you kind of how this works. So this is an example of a fluoroscopy from a LuX valve procedure. And the first thing that'll catch your eye before focusing on where the arrow is just noticing that the valve is deployed from the SVC. So the access is actually internal jugular and SVC access. So there's a lot of action going on at the patient's head and neck. You have anesthesia, you have interventional echo, and you have the interventional structural doctors. So everyone's kind of in that area. And so that's how this deployment system was designed. Focusing where the arrow is, so the valve's being lined up in the appropriate position, and then the clip is restarting now. Those are the two rabbit ears or bunny ears. And so they're being lined up with echo guidance, and they're being deployed, and they kind of flip up. And you see, and the idea is that they capture the anterior and posterior leaflets with that flipping up motion. And that's one of the ways the valve is anchored. That looks cool. All right, so next the valve is expanded and the atrial skirt is unfolded. The valve starts to take a shape that you might be familiar with looking at kind of the picture up on the top right, the head side of the screen. And then on the left, when the operators are happy, they're lining it up in the position that they like. And then on the right-hand side, when we're very happy with the position, the septal anchor is deployed, and that's where this where the yellow arrow is. You can appreciate comparing the two images side by side. There's now this like staple or anchor within that tongue that touches against the interventricular septum to actually help anchor it into place. So it's very, very kind of clever and interesting design. So how does the valve look on transthoracic echo? Well, this is the RV inflow view here. You can appreciate the central, cage of the valve, which contains the bioprosthetic valve leaflets. But one thing you can also appreciate is that one side, so on the septal side of the valve, it looks to extend a little bit further than it does on the opposite side towards the free wall. And so that's the septal anchor. We'll see it better in the other views. That's one thing that can be appreciated and unique about this valve. Not that we would expect to know what this valve is necessarily. With just the echo itself, we would have operative reports and other things to help guide us. But there are some unique features of this valve. So this is a color compare sweep of the LuX valve in the RV inflow view. So just focusing on the left-hand side, sonographer sweeps, and where the arrow is, you see that bright bit attached to the septum. That's the septal anchor, and now the cage comes into view. Bioprosthetic leaflets are opened up there. And they continue to scan through the valve, and then looking at color, one thing we've noticed is that around the septal anchor there tends to be a lot of color, and that's just flow around the anchor and the right ventricle. So it doesn't necessarily indicate anything pathological. It's just kind of flow, but you do see a lot of color in that area as well. It tends to be pretty bright.
Sorry, some of that is GE color artifact.
Fair enough.
Actually, a fair bit of that is GE color, right?
The other thing with this, these valves is don't forget if you can get a good look at the leaflets, because the low flow, we are more worried about sort of thrombosis on the valve leaflets. So, usually you'll see the gradient goes up. It won't be typically 2 or something, it'll be 5 or 6.
Chi makes the same point about the color artifact.
So have a good look for that as well. But yeah, GE color, I must admit I ignore that sort of in between turquoisey stuff. I don't really
Yeah.
put any weight on it. It doesn't mean it's not real. I just not certain if
No,
it is.
it
And
could
unless
have
there's
Anything, yeah.
confirmatory evidence, I would just get rid of it. Yeah.
Yeah, it overlies and hugs the surface.
Yeah.
Yeah.
You see that a lot on TE, actually.
Okay, because yeah, it does seem to be pretty prominent with
Yeah, that's all.
with this, you know.
Ones over the struts are
Definitely. So this is the RV. Sorry, this is the like an RV focus view apical forward chamber, and you can appreciate where the arrow is. That's showing where that septal anchor is.
And we tend to use the LuX valve here for those folks that really do massive
Yeah.
annulus, right?
Yeah.
So all the folks we did this week, you know, were 65 millimeters on CT, really enormous. And that's where this valve probably has the edge at the moment, because you can get it up to that size, whereas the other ones you can't use. If they just don't have the ability to actually anchor in properly, and you'll get leak, or you'll get valve fire off and float around. So yeah.
And that's a nice transition to talking about heterotopic valve replacement. So this is the last topic we'll talk about today. So heterotopic, you know, refers to the fact that we create a tricuspid valve outside of the native tricuspid valve annulus, and this can be useful for patients who have massive annuluses where you're not actually able to replace the valve via TTVR. And again, now the TTVR valves are also getting bigger, so it's going to be interesting to see kind of what ends up winning in the end, but this is another option that's being explored. So the idea is that a valve is created by inserting stents with valves into the SVC and IVC, and that's the trick valve down here. Or there's a very long stent which has valves that sit just above above the IVC and below the SVC, and that creates, essentially it isolates the right atrium from the systemic venous circulation. Now, the native tricuspid valve doesn't actually get treated. So this is a patient that has massive, annular dilation, a massive right atrium, a severe coaptation gap, and it was too big for TTVR at the time. And so this is an example of the design. So this is one of the heterotopic valves we've put in at St. Michael's Hospital. This is the Unica, and so it has a stent that sits in the SVC. There's a valve at the level of the SVC. The stent is then open in the area of the right atrium to allow blood flow, and then there's a stent at the inferior aspect of the valve, where just above the IVC. There's a skirt to try to help prevent paravalvular regurgitation, and then there's a stent that sits in the IVC. So this is an example of a similar valve. This is called the Trillium valve. The principles are similar, but the design is a bit different. So when I'm just going to pause this here. Perfect. Okay, so the idea is that when you have severe tricuspid regurgitation, the ventricular pressure is transmitted to the systemic venous pressure. And so this leads to high systemic venous pressures that give our patients uncomfortable symptoms, ascites, peripheral edema. And so is there a way that without treating the actual valve itself, we can actually help patients feel better? Dynamics. So this is the Trillium valve. Instead of having two stents or two valves in the below the SVC and above the IVC, it has a long covered stent, and then it has these three valves in the middle, which sit in the right atrium. So Dr. Leong Floy is impressed. So this is the transfemoral system. This is the transfemoral system. With fluoroscopy, the valve is the very long stent is lined up in the SVC and IVC. Once the operators are happy with the alignment, the SVC portion is deployed and expanded. And then it continues to be expanded. Again, this design is covered within the right atrium, and then it has three valves in the middle there. The Unica, which we have experience with, is open in the right atrium, and then there are valves above and below. But the idea is that now the systemic venous circulation has been isolated from the right ventricle. And so even though the patient continues to have native severe tricuspid valve regurgitation, that force is not transmitted, the pressures are not transmitted to the systemic venous circulation, and this may help patients feel better. That's the theory behind these valves. So this is a fluoroscopy showing how this procedure is performed. first, on the left-hand side, the stent is lined up within the patient's IVC and SVC. Then in the middle loop, the SVC stent, a portion is being expanded, and then it continues to be expanded down to the IVC. And so this is a patient that is post-Unica procedure. You can appreciate on the left loop, this is an RV inflow view. The patient continues to have severe native tricuspid regurgitation. There's a large coaptation gap, and that makes sense because this is not actually, the intervention is not treating this, right? It's not treating this. Where the arrow is, you can appreciate the stent in the right atrium. So this is a portion of the Unica stent. And then on the right-hand side is the color flow, and you just see color, just laminar flow from this wide open TR. This is an example of the stent being seen in the RA in the short axis view. And you can actually appreciate here, looking where the arrow is, there looks to be a leaflet opening. So this is the IVC stent that's opening up. And then on the right-hand loop, you continue to see the patient has severe TR within the actual TR, but the idea is what's happening at the level of the IVC. Well, this is an example of the same patient who has the Unica device deployed, and this is the portion shown within the IVC, and we don't appreciate significant systolic flow reversal. There's an initial upward portion of flow reversal, but the majority of flow during systole is downwards in the Doppler. So in this case, it looks like the venous circulation around the IVC has been isolated with the use of this device, and that's kind of the theory behind it. And with these, we're still like trying to understand exactly what we're seeing sometimes. So this is a different patient, and this sort of flappy bit caught our eye, and we were wondering. There was a lot of debate in the lab as to what this was, and eventually we agreed this is probably just the skirt of the stent in the IVC. But that's just something you might see if you see one of these devices in the future. And then color is applied to this area, and you can appreciate. I think I have an arrow here. I don't. We'll skip that. But I was wondering: is there any color flow around the stent? Is there any paravalvular regurgitation? So the sonographer here does a lot of movement around the stent to try to characterize and see whether there's color flow. We'll let this play for a couple of times. You can appreciate where the arrow is. There may be some red flow going around the stent towards the IVC. So there may be some degree of paravalvular regurgitation here. But it can be tricky, and this is where sweeping is very, very helpful to try to understand what's going on with these heterotopic devices. And so this is the same patient with interrogation of the hepatic veins. And what was interesting about this color, about this PW profile, is so in blue is the QRS. In red, there seems to be some early degree of systolic flow reversal, and then there's a more dominant systolic flow reversal with where the yellow arrow is. So we're trying to understand why this might happen. We thought with the red, perhaps this is that degree of paravalvular regurgitation. You see that early, and perhaps with the yellow, the RA pressures are still high, so that you don't have the valve's not open yet. It's not emptying in, and then that's why there's there's systolic flow reversal here. But the truth is, we're still learning, trying to understand these as we see more and more of these devices in the lab. This is a patient who had a Unica procedure as well, and in this case, the deployment to the IVC was not as ideal, and because these are devices that we're putting in with very large IVCs, and so in this case, the patient had a more significant degree of paravalvular regurgitation. And looking at the hepatic vein Doppler here, you can appreciate there's more early and more dominant systolic flow reversal shown with a red arrow. And so the last valve we'll talk about is the trick valve. So the concepts are similar. You're isolating the right atrium from the SVC and IVC, but instead of one long stent, it's two stents, each with valves. And so this is an example of the trick valve being deployed. It's deployed with echo and fluoroscopic guidance. On the left-hand side, the SVC stent has been lined up and it's now being deployed with a balloon. On the right-hand side, the IVC stent is being lined up using contrast and transesophageal echo. And then I thought this was a really nice clip because it shows a pigtail going into the right atrium through the IVC stent. And with color injection, you really see that right atrium opacify, but we don't see any contrast go into the SVC and IVC. So there's not significant paravalvular regurgitation. It seems like the SVC and IVC have been isolated with this intervention, which is what you want. And so this, if these loops look familiar, these were the loops I actually showed you at the beginning of the heterotopic section. And so this is a patient who's actually post-tric valve deployment. And it can be hard to see. It doesn't project entirely well, but from time to time you see a little fleck come in. And so with scanning and sweeping, we can actually appreciate some of these stents come into view from time to time. Again, the patient has native, severe, torrential, wide open tricuspid valve regurgitation because that wasn't treated with this intervention. We're trying to isolate the right-sided heart from the systemic venous pressure by putting in these stents. So this is a really nice image of the IVC stent in a patient post-tric valve procedure. You can appreciate with a color Doppler, there looks to be a little bit of regurgitation intravalvularly here, but we don't appreciate any paravalvular regurgitation. And on the interrogation of the hepatic Doppler, we don't see any flow reversal. And I really like this clip because the sonographers fan through it, and you appreciate a little bit more about the 3D geometry of the valve, and you appreciate the cage-like appearance of the stent. This isn't necessarily necessary, but it's just a nice image, so I included it here. And then this is a modified apical 4-chamber that opens up the coronary sinus. You can appreciate how dilated the coronary sinus is in this patient. And what we appreciate here in this view is, again, there's native severe tricuspid regurgitation. There's some degree of trace intravalvular, mild intravalvular regurgitation. We're looking for paravalvular regurgitation. And the sonographer, sweeps through. And we don't really appreciate any significant paravalvular regurgitation here, maybe some tiny jets. But when looking at these stents, it begs the question, are we looking at the SVC? Are we looking at the IVC? Kind of which one are we looking at, right? And we're probably looking at the IVC here because you saw it scan down towards the liver. And then it led me to ask the question, can we actually find the SVC on transthoracic echo? And those, worked in the pediatric realm or the congenital realm. No, there are techniques to do this. And so this was a review article I found from 2022 that went over 3 modified views of how to find the SVC and how this applies to our patients who have severely dilated right atrium and post these procedures. I don't know, but if anyone's curious, they can look up this article, and it describes some techniques. So the first is a modified 5-chamber view where the patient's halfway in between the supine and left lateral decubitus. The transducer is pointed in the 5th intercostal space, so in the usual apical window. But the device is pointed towards the patient's right shoulder, and then some tilting is performed to open up a view that looks like a modified apical 5-chamber view, and the SVC may come into view back here. This is a modified parasternal short axis view. So in our usual parasternal short axis window, again, the patient's positioned halfway between left lateral decubitus and supine, and the transducer probe is pointed towards the suprasternal notch. And with tilting of the probe, opening up of the SVC may be seen back here. And the view that I'm most curious to try is this one here, is a modified subcostal view. And so the patient's positioned supine, they were asked to flex their knees to help relax the abdominal wall muscles. And the transducer is a bit lateral to the upper mid epigastric region with the index marker pointed towards the right clavicle. And then by tilting the probe between -15, -45, so somewhere in between here, by tilting the probe in this sort of axis, the SVC may be able to be opened up. And so this is something I'm curious to try next time we see one of these patients.
Certainly this was Erwin Oshland. If you've ever listened to Erwin speak, he says you never need to do a TE. You can always identify the right upper and the SVC. You're looking for adult congenital heart disease. But this was the view he predominantly recommended, was the one as adult that we're much more familiar with, and pointing up was much more likely to open up the SVC and determine cable flow there. So yeah, it's tricky though, because we don't do it as a routine.
Right.
Yeah, and I think you need to do it routinely to get really good at actually saying, we think this is the SVC.
Right.
Actually, we actually do see the SVC flow fairly commonly on the subclaustals. We don't focus on it, but you actually can see it. So this is also probably the best way to get parallel flow for regurgitation.
Yeah.
And actually, studies have used this to look at SVC Doppler profiles as a sign of right atrial pressure elevation.
Excellent.
So the other comment I would make, Mike, with the heterotopic valve, I think, for everyone on the watching, that to me, in my mind, really is a more palliative end stage.
Yeah.
I mean, it doesn't really address the RV pathology. That means you're still not addressing the sort of right ventricular interactions there. So we don't want to wait until you get to that stage. So if in doubt, send people early. We can make an assessment, because although conceptually it's good, it really doesn't address a number of the key things that we really need to do, I think, to make a big impact on outcomes. There really is an end stage. There's not much else. People are in and out of hospital. They're an IV diuretics. We've got to pick one in, and we can't do much else. And that's when you tend to use it. So, it's nice technology, but I think it makes more sense if we can get earlier, is what we really want to be aiming for.
I agree. And I think with the TTVRs getting bigger and bigger, and we're getting more experience with them, I see those winning.
Yeah.
And then it also begs the question: what happens with the coronary blood flow when you have this high pressure system into the coronary sinus, and what happens from that end is I'm very curious as well.
Yeah, it's a good question, actually. It probably doesn't really address the reduced cardiac output that you get from the RTR.
No.
And in the first iteration of this, what we used to do was put in pulmonary stents into the IVC and then put an Evans sapien valve in backwards and implant it into the stent. So we created a scaffold to put it in. And we did a couple of those here. Unfortunately, what tended to happen though was we would fix the IVC, and so we might isolate the liver and the kidney. But in many times, I think we caused reflux up the SVC, and we saw a lot of neurohormonal activation, because the first two that I remember went into renal failure, and we could not get them out.
Oh, wow.
Right? They really just went down. The RV did not look substantially worse, so we presume there's some barrel reflex that we'd activated. So, there's other things going on in here. And
I think I remember those cases.
Yeah, you probably remember. We really were quite puzzled, because technically the procedure was very good, but and that's part of the reason why now we only isolated the IVC, because technically it was more difficult. We're using pulmonary stents.
Right.
Whereas here, these valves, as you know, designed either as a single or it's a tag team combo. So you do then isolate the SVC and the IVC. So it just tells us there's a lot of other things that we're activating when you put the stents in. So where possible, treat the actual pathology and not sort of address the regurg without actually fixing the RV and the pulmonary interactions.
Absolutely.
I just have a clinical question. Sorry.
Sure.
When you put in a header, so you talked about how when you put in the tricuspid valve, people may go into shock after. And presumably that's because their heart is adapted to what's happened, and then you're changing the pressures across the valve. When you put in the heterotopic valve, do we see people getting sick? Like, in the same way, because you're changing the pressures there. So I know they're more end stage and they're sick.
So I mean, in this case, the afterload to the right ventricle is probably not reduced nearly as much, right?
Fair.
As opposed to when you're placing the tricuspid valve annulus, and you've actually now you made the RV volume significantly bigger, because now it includes a huge right atrium, right?
It's a common chamber.
It's a common chamber, yeah. So I don't. I don't have a ton of experience in looking after these patients, obviously, post procedure, but theoretically, I don't think they would have the same hemodynamic response.
Part of the problem is we're just not as good at doing the RV quantification. The LV were better at saying, look, it looks down. Got a degree of mismatch. The RV, as Howard mentioned, we probably can't use TAPSI for a lot of these things. So we sort of look at it and say, fractional area change is really difficult to line up.
So difficult.
So I don't know how good the quantification is. 3D RVEF is a problem, because it's usually image quality, and they've got a big valve in the middle of it, and we can't put these people in the MR scanner. So it's been much more difficult to really tease it out. And the reality is it probably doesn't do a lot clinically. So what we do is, you have a look, if they're not responding, we give fluids. If that doesn't work, we make sure they're not on beta blockers, and we put them on milrinone and they go to the CCU, because then you're saying, okay, effectively removed every other cause and will support. The good news is they do usually improve though if you can get through that hump and you don't end up in renal failure. So.
And if you have IV failure, like, sorry, I know these are echo routes, not the echo routes, but in case we see this, like if their left side is down also, does that make a difference? I mean, presumably if they're that bad, their left side will eventually go down, right?
No, the ones I've seen, it's actually all been, it's been like an RV infarct. It's that really they behave as that scenario, and then what happens is the creatinine just goes up, and then we obviously have to, sled or whatever because they're hemodynamically not well. You've got them on milrinone, and then it's sort of a roll the dice. And then, of course, because we're instrumenting, you're much more likely to get infection. So then it usually activates that brand. And that, again, that's why I made the comment before about some of the valves seem to respond a little bit differently. So there may be something to do with the design where you can minimize blood mismatch, but it's also new. You just don't have the experience to be able to, and we're limited generally if it's larger, we go to LuX. If it's massive, we're going to do a heterotopic. If you can, we do a tier because it's the simplest and easiest. Otherwise, then you would use a Cardiovalve or a boat, right? That's sort of
absolutely. Well, I think Dr. Connolly's summarized my take-home messages in just that one statement, so that's excellent. We had a lot of good discussion. We're approaching the top of the hour, so maybe if there's any questions online, I want to thank everyone for their attention and participation. If there's any questions, Kavit?
Oh, I just want to add the view to see the SBC and I the IBC. So we do routine 2 views in peds.
Yeah.
So the view that you showed me earlier, what we do with that is to invert that view so it's correct. You'll see the correct anatomical rendition of the SBC and IBC using a 6 o'clock view.
Okay.
So
right, instead of pointing up towards the shoulder, invert. So then, it makes more sense.
You can see that. And the second one is the right lateral view. You'll see a bicable view.
Oh, like
right lateral view is where you go from the right personal view.
Oh,
similar to when you do your blind probe or AS, hold the clock and then tilt towards the right.
Okay. Awesome.
Yeah, it's also a view for to look at the atrial septum.
Perfect.
Thank you, everyone. It's now on the top of the hour. It's a great conversation, great, input from all the our expert colleagues, including our staff colleagues as well as our sonographers. And I guess, thank you, Mike, for putting all this together. There's a lot of work. You set the bar very high. And for all the audience, now, there's so many new devices, both on the left side for the mitral valve and also on the right side for the tricuspid valve. So we are one of the center of excellence at St. Mary's Hospital. So please, if you have patients that need the help, please send them to our structural heart clinic. And also, for our sonographers who are listening, as well as our colleagues in the community, you'll be seeing them. They'll be out there with you in your day-to-day practice. So stay tuned, and we'll be back next week. Thank you.